Welcome to Weekly Neurology Deep Dive. This deep dive is for educational purposes only and has no commercial intent.
Okay.
We're going to provide an overview of a fascinating paper about autoimmune nodopathies and the role of IgG4 antibodies, specifically focusing on takeaways you can use in your clinical practice.
Sounds good.
Remember, this is just a taste. We highly encourage you to read the full paper, The Discovery of Autoimmune Nodopathies and the Impact of IgG4 Antibodies in Autoimmune Neurology, for a complete understanding.
I'm glad we're tackling this topic. Autoimmune nodopathies represent a significant shift in how we think about certain cases of Guillain-Barré syndrome, GBS, and chronic inflammatory demyelinating polyradiculoneuropathy, or CIDP.
It does seem like this new category helps explain some of the more puzzling cases we encounter
Right.
as neurologists. Cases where a patient seems to have GBS or CIDP, but their presentation or response to treatment just doesn't fit the typical pattern.
That's exactly what sparked this research. For years, neurologists have noticed these atypical cases. Perhaps a patient with acute CIDP that develops much faster than the typical 8 weeks.
Right.
Or a patient with GBS who doesn't fully recover.
Yeah.
Or even the interesting connection between some neuropathies and nephrotic syndrome.
So how does this concept of autoimmune nodopathies help us make sense of these atypical cases?
Well, the key lies in understanding what's happening at the node of Ranvier. You'll recall that this is the tiny gap in the myelin sheath that's crucial for fast nerve impulse conduction.
Right.
In autoimmune nodopathies, antibodies specifically target cell adhesion molecules at the node, disrupting its structure and function.
And this disruption at the node of Ranvier leads to the variety of symptoms we see in these atypical cases.
Precisely. The paper highlights 3 main antibodies that neurologists should be aware of.
Okay.
Each one is associated with a distinct clinical picture, which can be incredibly helpful for diagnosis.
Let's break this down.
Sure.
You mentioned 3 main antibodies.
Yes. The first is anti-contactin 1, often associated with severe ataxia and, interestingly, nephrotic syndrome. So if you see a patient with ataxia and they also have nephrotic syndrome, that should immediately make you think of testing for anti-contactin 1 antibodies.
That's a very practical point. It sounds like a very specific clinical clue that could really guide our diagnostic workup. What about the other antibodies?
The second antibody to watch out for is anti-neurofascin 155.
Okay.
This one is often seen in patients with subacute CIDP, discal motor issues, and ataxia. It can also present with a very characteristic high-amplitude, low-frequency tremor.
Okay.
And here's a key point for neurologists. Up to 90% of patients with this antibody have a specific HLA haplotype,
Wow.
suggesting a strong genetic link.
That's a remarkably high percentage. It sounds like genetic testing could play a significant role in diagnosing these cases. What's the third antibody we should be aware of?
The third one is anti-CASPR1.
Okay.
And this one is frequently associated with severe and often difficult to treat neuropathic pain.
So we've got these 3 antibodies, each linked to a specific clinical presentation. How does that change our approach to diagnosis, particularly in those cases that don't fit the classic GBS or CIDP mold?
It gives us a more targeted approach. Instead of relying solely on clinical presentation and electrophysiology, which can be misleading in these cases,
Right.
we can now consider specific antibody testing.
You mentioned that electrophysiology can be misleading in these cases. Can you expand on that a bit?
Of course. One of the key takeaways from this paper is the contrast between electrophysiological findings and the actual pathology we see in biopsies.
Okay.
Nerve conduction studies in these patients often point to demyelination, the classic hallmark of CIDP. However, when we examine biopsies, we often see more axonal loss and less prominent demyelination.
So the electrophysiology suggests one thing, but the actual tissue pathology tells a different story.
Exactly. And this discrepancy highlights a crucial point for neurologists. We need to be cautious about interpreting electrophysiological findings in isolation, particularly when dealing with suspected autoimmune nodopathies.
That makes sense. So we need to consider the clinical picture, the electrophysiology, and now these specific antibody tests. It seems like we're getting a much clearer picture of these complex cases. Let's talk about those unusual IgG4 antibodies, which seem to play a central role in these conditions.
Yes, the role of IgG4 antibodies is fascinating and really changes how we think about treatment. Unlike their more common counterparts, IgG1-3 antibodies, which trigger inflammation, IgG4 antibodies work more subtly.
Subtle in what way?
Instead of causing a major inflammatory response, they disrupt their target. those cell adhesion molecules at the node of Ranvier by interfering with protein interactions. It's like a stealthy attack rather than a full-blown assault.
That's a great analogy. And this difference in how they operate has implications for how we treat these conditions, right?
Yes.
Specifically, the effectiveness of IVIG, which is a mainstay of treatment for many neurological conditions.
Absolutely. The mechanisms that make IV effective just don't apply to these IgG4 antibodies. They don't activate complement, they don't bind to the inhibitory Furgribe receptors, and they aren't neutralized by the idiotypes in IVIG. It's like trying to use a tool designed for one job on a completely different task.
So we're realizing that IVIG, which works so well for many other neurological conditions, may not be the best option for autoimmune nodopathies, particularly those driven by these IgG4 antibodies. What are the alternatives?
Well, the paper points us towards B-cell depletion therapies, and the results have been quite promising.
Because B cells are responsible for producing those antibodies in the first place.
Exactly. And since IgG4 antibodies are likely produced by short-lived plasma cells, targeting those B cells directly cuts off the supply of these problematic antibodies.
It sounds like a very logical and targeted approach.
Yeah.
Rituximab, a B-cell depleting agent, is mentioned in the paper. What has the experience been with using rituximab for these conditions?
Rituximab has shown impressive success in treating autoimmune nodopathies, which makes a lot of sense when you consider the role of B cells in their pathogenesis.
That's encouraging to hear. But this brings up another question. What about long-term management? Rituximab's effects can last a while, but eventually those B cells will come back. How do we handle that?
That's where careful monitoring becomes crucial. We need to keep a close eye on clinical status and IgG4 antibody titers. If those antibodies start to creep back up, it could signal a potential relapse and a need for retreatment.
So regular monitoring of both clinical symptoms and antibody levels is key to managing these patients long-term. And the paper also mentions something called a subclass switch. Can you tell us more about what that is and why it matters?
Yes, subclass switching is a phenomenon where a patient's antibodies shift from one subclass to another, for example, from IgG1-3 to IgG4 or vice versa. This is important because it can dramatically change a patient's response to treatment. A patient who was previously responding well to IVIG might suddenly become unresponsive if their antibodies switch from IgG1-3 to IgG4. And conversely, a switch from IG4 to IgG1-3 might make a previously unresponsive patient suddenly start responding to IVIG.
So it's a dynamic situation where the antibody profile can change over time, and that can have a huge impact on treatment decisions. This emphasizes the need for regular monitoring of antibody subclasses, not just the overall antibody titers.
Exactly. It's another layer of complexity we need to be aware of when managing these patients.
This has been incredibly insightful. We've covered a lot of ground from the initial challenges of diagnosing atypical GBS and CIDP cases to the role of specific antibodies, the unusual behavior of IgG4 antibodies, and the potential of B-cell depletion therapies.
And we've only just scratched the surface. The full paper delves into even more detail, including the limitations of current diagnostic tests, the potential for emerging biomarkers, and the exciting future directions of research in this field.
I'm definitely going to be recommending this paper to my colleagues. It's a must-read for any neurologist who encounters these challenging cases in their practice.
I agree. It's a game changer for neurologists. We can now recognize these conditions earlier, choose the right treatment from the outset, and monitor our patients more effectively to prevent relapses. Before the break, we were discussing the importance of recognizing and diagnosing autoimmune nodopathies. Let's delve a bit deeper into the practical implications of this research for neurologists in their daily practice.
That sounds great. I'm sure many of our listeners are eager to hear how this new understanding can translate into better patient care.
Absolutely. One of the most crucial takeaways is the need to broaden our diagnostic lens when evaluating patients with suspected GBS or CIDP. We can't just assume it's a textbook case anymore.
We need to be more alert to those atypical presentations that might point toward an autoimmune nodopathy. What are some specific red flags that should make us consider this diagnosis?
There are several key features that should raise our suspicion. As we mentioned earlier, a rapid disease progression is one. If a patient with CIDP develops symptoms much faster than the typical 8 weeks, that's a red flag.
So paying close attention to the timeline of symptom development is crucial. What else should we be looking for?
Unusual symptoms are another important clue. For example, if a patient presents with prominent ataxia or neuropathic pain, especially if those symptoms are out of proportion to the degree of weakness, we should consider the possibility of an autoimmune nodopathy.
And of course, a lack of response to IVIG, A treatment that's usually effective for GBS and CIDP can also be a telling sign.
Precisely. And this is where understanding those antibody associations we discussed earlier becomes so important. If a patient presents with severe ataxia and nephrotic syndrome, testing for anti-contact 1 antibodies should be a priority.
And similarly, if we see that characteristic high-amplitude, low-frequency tremor, especially in a patient with subacute CIDP, testing for anti-neurofascin, 100 to 55 antibodies would be warranted.
Exactly. Recognizing these clinical patterns can help us streamline our diagnostic workup and get to the right diagnosis more efficiently.
It's like having a more refined set of tools to tackle these challenging cases. Now, once we suspect an autoimmune nodopathy, what's the next step in terms of diagnosis?
Antibody testing is key. The paper emphasizes the importance of using reliable and accurate methods for detecting these antibodies. Not all tests are created equal, and some techniques can be prone to false positives.
So we need to be discerning about the tests we order and interpret the results carefully.
Absolutely. For the most accurate results, the paper recommends using cell-based assays, preferably with live cells. It also stresses the importance of using a second confirmatory technique to rule out false positives.
It sounds like a two-pronged approach is necessary to ensure an accurate diagnosis. This is critical because, as we discussed earlier, the treatment strategies for autoimmune nodopathies can be quite different from those for classic GBS or CIDP.
That's right. Once we have a confirmed diagnosis, the paper makes a strong case for considering B-cell depletion therapies like rituximab early on, especially for patients with IgG4-mediated nodopathies.
Because those IgG4 antibodies with their unique mechanisms of action often don't respond well to IVIG, which is the mainstay of treatment for many other autoimmune neurological conditions.
Exactly. Targeting B cells, the source of those troublesome antibodies, seems to be a much more logical and effective approach. And the research has borne this out. Rituximab has shown impressive success in treating autoimmune nodopathies.
That's really encouraging to hear. It sounds like we're moving toward more targeted and effective therapies for these conditions, but as we discussed earlier, the effects of rituximab, while long-lasting, aren't permanent. How do we approach the long-term management of these patients?
Long-term management hinges on careful monitoring. We need to closely track clinical symptoms and IgG4 antibody titers. If those antibodies begin to rise again, it could signal a potential relapse and a need for retreatment.
So vigilance is key. We need to be proactive in monitoring these patients and ready to adjust treatment if necessary. And the paper also highlights the potential of emerging biomarkers, such as those CD27 plus memory B cells, to help predict relapses before they even happen.
That's right. Imagine being able to identify patients who are at high risk of relapse before they even experience symptoms. That would allow us to intervene earlier and potentially prevent those relapses altogether.
It's like having an early warning system for disease activity. It's an exciting prospect that could really change how we manage these conditions in the future. It sounds like we're entering a new era of personalized medicine in neuroimmunology.
I agree. We're moving away from broad categories and blanket treatments towards a more individualized approach, tailoring our diagnostic and treatment strategies to the unique characteristics of each patient.
This shift toward personalized medicine is truly transformative, not just in neurology, but across the entire field of medicine.
Absolutely. And this paper is a fantastic example of how scientific breakthroughs can translate into real-world clinical benefits.
We've gone from being baffled by these atypical cases to having a much clearer understanding of the underlying mechanisms and a growing arsenal of effective treatments.
It's a testament to the power of scientific inquiry and the dedication of researchers who are constantly striving to improve patient care.
And for those of you listening who want to delve deeper into this world of autoimmune nodopathies and explore the nuances of this research, I highly encourage you to read the full paper.
It's a rich resource that will deepen your understanding of these conditions and inspire you to join the quest for even better treatments and ultimately a cure.
Before we wrap up, I'd like to touch on one more point that the paper raises. It emphasizes the importance of collaboration and communication in managing these complex cases.
That's a crucial point. Autoimmune nodopathies often require a multidisciplinary approach involving neurologists, nephrologists, immunologists, and other specialists.
It's not just about treating the neurological symptoms, but addressing the broader systemic implications of these conditions.
Exactly, and effective communication between these different specialists is essential for ensuring that patients receive comprehensive and coordinated care.
This paper has been a real eye-opener, shedding light on a group of conditions that were once shrouded in mystery. It's exciting to see how our understanding of autoimmune nodopathies has evolved, leading to more precise diagnostic tools and more effective treatment options.
I couldn't agree more. It's a testament to the remarkable progress that's being made in neuroimmunology, and it's only the beginning. As research in this field continues to advance, I'm confident that we'll unlock even more secrets about these conditions and develop even more targeted and effective therapies.
It's a hopeful time for both patients and neurologists. And on that note, we'll wrap up this deep dive into autoimmune nodopathies. We hope you found it both informative and inspiring. We encourage you to continue exploring this topic, share your insights with your colleagues, and stay tuned for more exciting developments in the world of neuroimmunology. Until next time. As we wrap up our deep dive into autoimmune nodopathies, I keep thinking about the paper's emphasis on personalized medicine.
It's an important concept,
Yeah.
and one that is particularly relevant in neuroimmunology.
Especially when we consider how diverse these autoimmune nodopathies are. Even though they share some common features, each patient can present with a slightly different clinical picture, respond differently to treatments, and have different long-term outcomes.
That's why a one-size-fits-all approach just doesn't work. We need to tailor our diagnostic and treatment strategies to each individual patient.
And that's where a deep understanding of these IgG4 antibodies and their unique characteristics becomes so crucial.
Absolutely. Knowing which antibodies are at play, their subclass, their titers, and even their functional properties can help us predict how a patient might respond to different therapies.
It's like having a personalized roadmap for each patient's journey.
Precisely. And as we learn more about the genetic and environmental factors that contribute to these conditions, we'll be able to personalize our treatments even further.
It's an exciting time to be a neurologist. We're moving away from those broad categories and embracing the individuality of each patient and their disease.
This paper is a fantastic example of how scientific breakthroughs can translate into real-world clinical benefits. We've gone from being baffled by these unusual cases to having a much clearer understanding of what's going on and how to effectively manage them.
It highlights the incredible power of scientific curiosity and the dedication of researchers who are constantly pushing the boundaries of knowledge.
And for those of you listening who are as fascinated by this topic as we are, I encourage you to read the full paper and dive even deeper into this world of autoimmune nodopathies and IgG4 antibodies.
It's a journey of discovery that's well worth taking. I think this deep dive has been incredibly valuable, offering practical insights for neurologists and highlighting the remarkable progress being made in this field.
I agree. It's a truly inspiring time to be involved in neuroimmunology with so much potential for improving the lives of patients with these complex conditions.
We hope this episode has sparked your curiosity and inspired you to stay informed about the latest developments in this rapidly evolving area of neurology.
And remember, the knowledge we gain from research is only as valuable as our ability to apply it in clinical practice. So let's continue to learn from each other, share our experiences, and work together to advance the care of our patients.
Thank you for joining us for this deep dive into autoimmune nodopathies. Until next time, keep those brains buzzing.